hello, and welcome. We'll give just a few minutes for people to get logged in. If you would drop your, I'm going to say howdy, and y'all know why I'm being spiteful and saying howdy, but I grew up saying howdy, but I'm going to say howdy for that other reason. Drop your hello in the chat. Let us know where you're joining us from. My name is Marie Boone Clark, and I'm the founder and executive director of Birthing the Magic Collaborative. And I am so excited this afternoon, if you're on the West Coast, evening, if you are on the East Coast, but we're going to talk about what this is all about. You've carried the baby, and now that tiny human has to come out. So let's talk about how that happens. So we'll give another minute and allow people to get logged in, say hello, and then I'm going to introduce my co-conspirators for the evening. And we'll get started. If you haven't picked up your cocktail for the evening, do. And if you don't drink cocktails, not to insult, you can always have a coffee, which is probably what I need. So, joining me this evening is Dr. Audra Robertson Meadows, Renee Byfield, and Melissa Nelson. I'm going to ask Melissa to introduce herself first, share a little bit about her. I always do the bios, and I tell people what you say on paper is not necessarily what you would really want to say out loud. So I'm going to ask Melissa to introduce herself.
Welcome, everybody. So my name is Melissa Nelson. I am the Chief Midwife at Mass General Hospital for our midwifery division. It is so great to be honored, and I'm so honored to be a part of this conversation. And I'm thrilled to get to kind of share our knowledge and allow this to be continued group knowledge with everybody.
Thank you, Melissa. And Renee?
Yes, I'm also honored to be with you all. I am the program director of the Speak Up program for the Institute for Perinatal Quality Improvement. I'm glad to be part of this conversation.
Thank you, Renee. And Dr. Audra.
Hello, everyone. I am very happy to be here as well. Very happy that we have this forum so that we can continue to raise awareness and bring attention to Black Maternal Health Week and all that we're working toward to improve and support the births and the family development of our communities. I am a practicing OBGYN. I am both bi-coastal. I am both in San Diego, at University of California in San Diego as a professor and vice chair for culture and justice. And importantly, I lead work related to birth equity in California, but I also am leading work in the state of Massachusetts as one of the founding directors of our state perinatal quality collaborative there. Called PNQUIN, the Perinatal Neonatal Quality Improvement Network of Massachusetts. In that work, we also lead the Maternal Equity Bundle currently as our current work so that we can address inequities in maternal illness and in maternal death so we can improve these experiences and outcomes for all of us. I'm very happy to be here.
Thank you, Dr. So guys, talk about, when I was first describing this to someone, I said, this is going to be like the cliff notes for how do I choose the best facility? How do I know what my best options are? But to think that your cliff notes are coming from this esteemed group, talk about, as my co-partner with Birthing the Magic, Dr. Valencia Walker always says, Black girl magic. I think we've got that in the room today. So I'm going to share my screen and we'll get started. Just chatting a little bit about, well, first of all, we often hear this whole question of, should I be induced? Or maybe we should back up before we get to the point of being induced. I've heard so often that almost equal to the physician that you select, the provider is equally, the hospital is equally important. Is that true? And how would we go about identifying that? Do we start with that question? And should I go to the next slide?
Yeah, if you don't mind going to the next slide, I'd happy to start there. So what's important to know about giving birth in the United States? We've definitely read and heard the news reports in the media that in this country, all women, all birthing individuals are at elevated risk of outcomes that we're not looking for. As a provider, but also as a mom and someone who's had a baby before too, my goals were healthy mom, healthy baby, great outcome, term delivery, right? Near or around our due dates, and a good experience. Those are my goals personally. Those are also the goals I have for the patients that I serve and the communities that I serve. And I like to match their goals with the care that they're receiving also. In doing that, though, it's really important to think about who the right provider is. So if you want to go back one more slide, if the right provider is actually the person that you work best with, that you feel confident and comfortable with, that you feel that you get to be seen, heard, and valued. And in doing that, that's also in consideration of where that provider is delivering care. And so I say provider, I'm saying that specifically, I'm choosing that word because it may not be a doctor, it might be a midwife. It may be a certified nurse midwife. It also may be a home birth midwife, if that's who you're working with and it's a safe and a valuable relationship that you're engaging in there. And with that, we work in systems. We work to deliver at either a healthcare system, in my case. Some people work at birthing centers, and whether that birth center is a hospital-based birthing center or a standalone community birth center, those clinical systems where you're choosing to give birth really matters. And making sure that you're delivering and giving birth in a place where you are both seen, heard, and valued, and the delivery and the care you're receiving is safe. And that's the goal.
And I would add to that a little bit in that, we all know those facilities in our communities where we're treated with a modicum of respect, and I say that purposefully, and that your family members are treated. And I think that respect is not a big enough word, frankly, because we need to be more than respected, right? Listened to. So use your instinct in that when you're coming into these systems, bring your family, bring your loved ones to help hear in a different way and be able to ask questions. And that should guide also your decision making. How do I feel in this space? Am I being listened to? Am I being given options? And we all know, I come from New York and I'm currently residing in Georgia, and I knew exactly where to take my family members if I wanted to. Now, you could say I'm an insider as a clinician and a nurse, but again, you hear in the community and you can vet them well before having that delivery or birth or that experience in pregnancy. So just wanted to add that as a practical tip.
And I think in addition to that, you want to think about what are some of those questions that you can ask. So just like Renee said, and just like Dr. Meadows said, you want to think about where will you be respected, asking them what is their rates, what is their primary C-section rate, what is their postpartum hemorrhage rates, if you are a first-time birthing person, what is the likelihood that you can have a successful vaginal delivery? Those are key questions to really think about, thinking about what other providers do they have. Just like Dr. Meadows mentioned, you can be seen by a physician, and there's also different types of OBGYNs. You have maternal fetal medicine doctors, you have some people call them OBGYN specialists or generalists, and then you also have midwives, and thinking about, is it a midwife that delivers at a hospital versus a birth center versus a home birth? So I think these are some of the most important questions that you want to really be asking. Also, even thinking about, what is the likelihood that you will be the one that's delivering my child? We work in a very big group practice. And, I think it's something that people really want, that intimacy. They want to know, you are my provider, you're going to deliver me. However, sometimes that may not necessarily be the case. You can go to practices where that provider is your sole provider and understand that there are pros and there are cons to both, but also really understanding, is it someone from your practice that's delivering me, or is it somebody from somebody else, another place that could be delivering me? Some hospitals have laborist practices where you have your provider in the office, but it's a different subset of providers on the floor. And I think another big thing to really look at is also asking about your nursing staff. Nurses are the crux of what we do, right? So it's not just your midwife, it is not just your doctor, it is your birth team. So what are the nursing support? What education are they giving to those nurses? And really understanding what are some of the rules, what are the regulations? Do they have different types of monitoring? Do they have showers and tubs? Do they have early discharge processes? So if you want to go home within 24 hours, because you want to go home within 24 hours, asking a couple of those questions as well, and even thinking about what is the care that they provide. Do they work with doulas? Do they work with birth well wishes or plans, as some people like to call them? These could be some really good questions that you can be able to ask when you're trying to figure out what site is it and which provider that you really want to be able to have that person take care of you.
I'd also add too, I appreciate everything that's been said. And I'd add that one thing you can ask a provider, and hopefully they can answer this question, is does their institution participate in the AIM program? And so the slide that you're on now shows the caption for the saferbirth.org webpage on patient safety bundles. And AIM stands for the Alliance for Innovation on Maternal Health. And this is a national program that has been around for a few years now, as many institutions across the US have been working to respond to a call to action, if you will, about what's been happening as we've seen these rising numbers of maternal death in the United States. And many of you may have heard this already through some of the other virtual webinar talks and other talks you might have listened to, but as the numbers in the United States continue to rise, the numbers in other countries are continuing to go down. So it says something, not about the individuals having babies in the United States, it says something about the systems of care in the United States. So this issue we're dealing with as we think about safer, we want the word to just land on safe, and now we need to keep pushing for safer. And as we move towards safer births, we need to understand how our systems engaged in this. And is the healthcare system that you might be choosing to deliver at participating and making sure that they're engaging in this work? And quite simply, what is AIM? AIM is a list of patient safety bundles. There's a lot of ways that different hospital systems can implement those safety bundles. They use it through what we call the improvement process, using these techniques around what's called quality improvement in order to get those particular metrics and actions put in place, and then measuring the accountability around that. And there is one that we're doing, as I mentioned earlier, in Massachusetts, and some other states have done as well, California and Illinois and New York, looking at maternal equity and thinking about how do we not only improve the care we're giving and making the hospital care safer, how do we also ensure that it's safe for all populations and not just an overall population, like really disaggregating and pulling out, and what I mean by that word disaggregate, pulling out and really pulling out, looking at each population based on, is it the same for those who speak English and those who don't speak English to get care here in terms of their deliveries? Is it the same for those who identify as Black and those who do not identify as Black? Those kinds of things. And safety bundles help teams to do that work, help hospitals to do that work, help to maintain and elevate that accountability. So one of the questions you could also ask is, are you participating in the Alliance for Innovation on Maternal Health? Now, I also noticed in the chat that Dr. Martin put into the chat around looking at the Earth app. And I know that the leaders of the Earth app have also started to have conversations with PQCs to understand how we can help partner, so that part of a metric related to what hospitals are performing well could also be this. And I just like to always introduce and say, when we're talking about patient safety bundles, what we're saying is hospitals need to live up to the word hospital. When you walk into a hospital, it should feel like the place you go to get safe care and your life is in good hands. And with that, you need to not have to know what doors to walk through in order to get good care. You should be able to go to any place and have that. And that's what folks who do this work with AIM and patient safety bundles are working towards. Per state, each state is working on making sure that all of their hospitals live up to that name hospital and that their birth can be safe in those spaces. So I think that's something else that you can add.
Excellent points. Excellent points. Now, one of the things that, if we could, just one follow-up question for me as a lay person, and I hope some of those in the audience are as well, and have that as a burning question. Why do I care about the postpartum hemorrhage rate?
You care about the postpartum hemorrhage rate because postpartum complications after delivery and during delivery can essentially impact your maternal morbidity and mortality. And you care about that because, you know, you deliver, we anticipate that you have some blood loss, but sometimes some people can have significant blood loss. Sometimes some people their iron levels already a little bit lower. So maybe if they lose 500 cc's, they may not feel it, but maybe if you start off with a lower iron storage, you're probably going to feel it a little bit more than in comparison to someone who starts with a higher iron storage. And we also do know that we have patients, we've heard scenarios where people have died from postpartum hemorrhages, right? So understanding, are we using evidence-based protocols? Are we utilizing resources to things to say, not when it gets there, but what can we do to prevent it from getting there? So as a provider who came up in the generation of, you know, oh, it looks like it's probably like 200 cc's, right? And then now you have to start measuring it. And, you know, as someone who went through an institution that changed it, I was like, oh my gosh, what is this? And I'm like, I know what if it's this, but then you have a situation and you're like, wait, like you really lost 1.5 liters of blood. And I would only think that that's actually only 500, right? And remember, everybody is different. How some people feel when they lose blood can be totally different. So postpartum hemorrhages can occur. They can occur for a variety of different reasons, whether your baby's big, whether you have other medical chronic conditions such as diabetes, high blood pressure. Maybe you were laboring for a very long time. Maybe you pushed for a very long time. And when you think about that and you think about how vascular that placenta is and how enlarged your uterus is at the time when you are giving birth, something like a postpartum hemorrhage, you want to make sure people are using evidence-based practice and they're doing things to prevent it from occurring, right? Because that's where you find a lot of the issues and the disparities is that, hey, there was a method that could work, but they weren't using that method. So just that would be an example.
And I'll add piggyback onto that. So they may not know the rate or the hospital may not be candid about the rate, right? But the action, and Melissa's alluding to this, quantifying maternal blood loss, is that happening at your institution? May be a way of asking, are you being proactive prior to the event? Are you measuring before the event, as the delivery is occurring? Are you measuring my blood so that we're not waiting to the aftermath to figure it out? Right. And quantifying blood loss is one of the things that we've instituted recently. I say recently in that I would say the last last 10 years, and a lot of the hospitals are not doing it, but that's a crucial component to understanding what the blood loss is proactively, as opposed to waiting, like Melissa said, till after the fact when the patient starts deteriorating. And it's better than what we used to do is guess, like Melissa said. We used to guess and in terms of now that it took some training, but still guessing is not as good as measuring. So asking, do you quantify blood loss, maternal blood loss at deliveries might be something that is a strong question to ask, a good question to ask.
Yeah, and I'd say that's also a specific question to ask because one of the safety bundles is the obstetric hemorrhage bundle. OB hemorrhage is one of the leading causes of maternal death, like as Melissa said. And what's important about this thing about quantification is measuring, because we know from a research standpoint that it world over from the 60s forward, there have been researchers that have been able to say, hey, when we as human beings look at a puddle of blood and estimate how much it is, we often underestimate large blood volumes. And that's how people bleed more and find themselves in jeopardy if we're estimating, and that we overestimate small blood volumes. And so we're not getting it right is what basically that's saying. And so if you quantitate, there's different ways that people can quantitate. They can weigh it. They can use these little fancy systems where you can take a picture of it. It's called photometric, or you can just, look at the amount of volume in like a something graduated that you can measure it. And importantly, measuring it over time, because the amount of blood you lost on one unit floor, which might be the labor floor, needs to continuously be added to any blood loss you might have in postpartum, which happens, after you've changed floors and gone upstairs or downstairs or to the other side of the unit, whatever postpartum is for them, for a person. And then when you add them together, you don't now have that difference of like 12 to 16 or more hours where one person might have seen how much blood loss was one and another person sees blood loss. Well, you need to know that the system has all of your blood loss together quantitated so that anyone can intervene. And so again, that comes down the road to these questions. If you go to the next slide, actually, Marie, what I was also going to share is that this is just an example, but there are other state perinatal quality collaboratives that are doing this kind of work too, implementing these obstetric hemorrhage bundles, making sure people have hemorrhage carts that are updated, making sure people have systems for quantitating, make sure there's training for quantitating blood loss. And I like what Renee said, because when you asked the question, I thought, most people won't know a rate, right? You know yourself when you're having a baby, you're not really going to get away with having a baby without losing some blood. That's just the bottom line. Everybody bleeds to a certain amount. The goal is not to bleed too much, but at times people do. And here's the important part. Black women had been dying of obstetric hemorrhage at rates greater than other people. Black women do not hemorrhage more than others. We don't bleed more, but we were happening to die more often when we did bleed, and that was scary. And when we were able to start putting in place these safety bundle metrics and these safety bundle actions, then you were able to see people have a hemorrhage and have timely intervention, because it's not just the intervention, it is doing it in an amount of time that is short, so that we can really make sure that people stay safe. And that's key. And this particular bundle that my team had led here in Massachusetts, that you're looking at this slide for the maternal equity bundle, what we were looking at is how you implement the safety bundle and not just measure, did everybody, quote unquote, the population get their blood loss measured and have risk factors for hemorrhage being identified to the team. We looked at, did each population, like, was there a difference between who was getting their blood loss measure based on whether they were, based on their race, based on their insurance status, whether they were Medicaid or non-Medicaid, based on their language, those kinds of things, making sure that we're not missing groups of people. Because if you're going to a hospital where there are a few people who identify as Black, and you look at the population, it's going to get washed out. So everyone could say, sure, we measure most all, but you want to make sure there's no difference. And that's what happens when you look at your information in a hospital system. So I wouldn't say that a person typically, and I also pause because in my experience, and I don't know if this is yours, Melissa, no one's ever come in and asked me our hemorrhage rate per se. They usually say, am I going to bleed heavily? And if I do, what are you going to do to help me? And I explain, I only work in hospital systems that implement these safety checklists, so that way we're making sure that everybody's in good hands.
I agree. And I think one thing to also think about, I think, Malcolm, you had asked about trauma-informed approaches to some of these measures. I think in any aspect, and, as a midwife, we look at the holistic person, we look at yourself, we look at the mental health, we look at your emotional well-being and your physical well-being, we look at your family as a part of this process, right? So anytime having any of these conversations, or if any of these things are actually occurring, taking a step back and say, how does this affect that family? So I know I've been in situations, and I think even with some of our trainings, that when you are having emergencies, or what we deem as obstetrical emergencies, that there is somebody there talking to the family. This is what's going on. This is what's going through. This might look a little bit scary, and having those conversations, and also recognizing, like, yes, it is a fear, because, I'm sure there's many people on this conversation who are in reproductive age, including myself, who it's scary. It's scary when you think about all of those things, but also recognizing that some people do have good birth experiences, and there are good birth stories, but also acknowledging the fact that we must do our best to be that avid person, right? To be that person. If you can look up what the iPhone 15 is, and you can rate it better than what the iPhone 13 is, we should be able to do the same when it comes to childbirth and any of the things that could potentially happen too.
Well said.
Yeah, very much so. So two things that come to mind as you all are talking. One is the point that you made, Dr. Audra, in terms of if the hospital does have a practice in place where they are monitoring blood loss, and is it better that they say, well, we monitor more for people of color versus those who do not? Is that something that we're listening for, or is it simply we want to know that they have a protocol in place, that they're following these practices?
Absolutely. It's probably more the latter. And I'd say if you go to the next slide, we talk about this a little bit in this slide, and I think it's a good visual for many people who've probably seen these kinds of images when we talk about equality and equity. When you look at this image to your left, the equality, and each person there who is expecting is reaching for their fruit, and only the person who's orange is able to touch that, right? And that's their goal, is to be able to reach this pair. And so the boxes that they're standing on are the same height size, they're equal. And there's something about the concept of equality that people feel like, well, that's what we're looking for, equality. Equality assumes that everyone benefits from getting equal or the same support, and we can see that that's not the case here. Now, their boxes over to the left of the person who's orange show that there are other boxes in our healthcare system. Those are the things we can do to support each individual. So equity is the picture to your right. That's where everyone gets the support they specifically need to attain their full health potential. Now, those baseline boxes are still there, but the additional boxes are always available that we can bring to each other. And that's where we do our individualized care. So if you think of the safety bundles as, or any checklist, how clinical systems give their care, that is the first set of boxes. And then, for example, when everyone has a baby, they usually leave the hospital with a discharge summary, with something that explains what happened and the kind of care they got, what medications they got, when their next appointment is, those kinds of things. Now, when you give someone a discharge summary in their native language, in Spanish if they speak Spanish, in Haitian Creole if they speak Haitian Creole, in English if they speak English, now we're talking about equity. And we're giving people what they need to get what they, attain their fullest health potential. So that said, when you ask about hemorrhage and you're talking about the measurement, it's important not to what we call qualitatively measure, meaning look and guesstimate, but to quantitatively measure, meaning actually get a full number so that you can act upon that number. And there are very specific numbers. Just because you bleed in pregnancy doesn't call it a hemorrhage. There's a certain number we hit that we start to think of it as a hemorrhage, and a rate that someone's approaching that number that we start to act thinking this may be leading down the path that we don't want to go down. And when that happens, it's not that you're looking at that person's individual demographic characteristics right then. You want to treat everyone to what they need with this equity model. The basis of that equity model are your protocols, right? And so someone had put in the chat the question, does inducing labor increase the risk of blood loss? Well, it would depend on the type of induction, for instance. So to your point of hemorrhage, if we induced using acupuncture and that worked, that's not something that's usually going to increase your risk of bleeding. If we induced using medications that we use in labor, for instance, Pitocin, that could increase your risk of bleeding depending on how long that Pitocin's been going, how much of that total medication you've gotten. Also, simple things like the number of children you've had. If this is your 5th or 6th vaginal delivery, then your uterus may, be more relaxed. And then after you have a baby, that particular type of uterus could bleed more. So we watch for these things. Those are things that are in the back of our mind as we're watching labor progress. So individually, there are many different reasons why an labor induction could increase the bleeding. And there are people that could have their bleeding increase even when they're not induced. But all that being said, making sure you have a protocol where what we do in many hospitals, the ones that also implement these checklists, is we do something called a hemorrhage risk score. And it's a color-coded in many hospitals key on the side of the person's name. Usually in your electronic systems, there may be other ways people do it, but that gives us a sense of understanding who is at greatest risk of bleeding, so that we're all keeping in mind someone that if we hear, in the loudspeaker that this number is being called and come to this room, those kinds of things, like we are attentive to that. So we have our protocols in place, we have our medications ready to go, we have our hemorrhage cards ready to go, we make sure that someone's assigned to making sure that the medications aren't expired and that the card is nearby the rooms and all of those things. Make sure that we're not out of supplies. Those things are just the basis, the readiness. We're trained, and we do training often in simulations to make sure that we're ready to respond in a clear and decisive fashion. And then on top of that, we have this risk scoring so that we're looking at people individually, and that risk scoring updates and changes based on other things that we know based on the medical literature that may or may not increase your risk of bleeding. So what I'm saying is there's a plethora of details that we could get into, but overall the goal would be, am I delivering in a hospital that is safe? Because this hospital thinks about these things, trains on these things, has protocols for these things, and participates in a national program where everyone is working to make sure that hemorrhage is not a reason why someone doesn't go home with their family after a birth. Okay.
Mhm. That's a good explanation. Good way for us to envision what you're describing, that there is the basis of what is done as standard protocol, and then the extra boxes to the side are what you have to do more tailored to my needs. So we're talking about hemorrhage. Many of us can probably think of a person in the media that we've heard about that died from a hemorrhage. So we have interviewed, we're interviewing our provider, we're looking at different birthing facilities in our community. How do we get to the question around, and I think I'm going to your next slide, how do we get to the question around, I've attended this workshop, I know all of this, how do I ensure that my voice is heard? Is that going to the next slide?
It is.
Yep.
Yeah, I was going to say it is. I think if you go to the next slide, then we can talk about what happens in many of the healthcare systems that are receiving training right now to address issues around respectful care and also being anti-racist.
Thank you. One of the things that I think we need to understand, that there needs to be a multi-pronged approach to how we mitigate the issues and where we are now with Black maternal mortality, right? And one of the strategies is really focusing on the providers and how, and when I mean providers, I mean all of that healthcare team and how they're treating patients as they show up. So one of the things that I do is I'm program director at the Institute of Perinatal Quality Improvement. We have the Speak Up Against Racism program, and it's based on a birth equity curriculum that's aimed at facilitating the elimination of perinatal disparities and addressing the Black maternal mortality crisis. Our goal is to use quality improvement science and methods. And I will say that when we got the AIM bundle and the focus was on how do we fix this Black maternal mortality crisis, and it didn't feel actionable, right? And clinicians need actions. And that's why having a focus on and empowering perinatal professionals and teams to create their own action plans focused on dismantling structural inequities and processes was the goal. It gave them something to work towards, but also looking introspectively at how am I showing up and how am I treating my patients. So I said earlier that it's beyond respect, right? It's looking at how am I, based on my biases, my implicit biases, my explicit biases, looking at myself, how do I modify, how do I change myself or how I treat patients so that our patients are treated equitably? And Dr. Meadows did a beautiful job of describing what is the difference between equality and equity. We have extra boxes. We just need to give patients individualized care so that they can also reach that fruit. So far, we've educated about 1,600 perinatal professionals in 37 states and collaborated with leaders of departments of health, PinQuing, as other perinatal quality collaboratives, universities and organizations, and supported the launch of statewide birth equity initiatives in 5 states that include, again, Massachusetts, Georgia, Connecticut, and Illinois. And it's based on the acronym that you see on the screen, Speak Up. And I tell you, none of these are easy, even though it seems common sense. So set limits, practice and prepare, express your concerns, apologize, keep improving, uncover and learn, and persuade others. And again, focusing on how do I look introspectively so that I can then, and how do my implicit biases affect my decision-making as a clinician? So it's been very successful. Next slide, please. Sorry, can't see the slides. And we acknowledge, and I know probably a lot of you have been involved in DEI courses that are an hour, and all of a sudden racism is going to disappear, right? No, it's not. So we are very committed to this action pathway that is again, multi-pronged. It's a continuous journey. And the first step in this journey is engaging, learning, and mobilizing, starting a Speak Up committee or work group, completing the implicit association test assessment, and again, looking at yourself, where do you land? And that is all of us, because all of us have been conditioned to see people in a certain way based on social media, advertising, and even I was surprised at my first implicit bias result. So completing the online education that we have, and then step two, again, completing the Speak Up Champion course that we have, which is an 8-hour course where we have different activities to really have introspection and think about and talk about that elephant in the room, racism. We again have them engage in developing SMARTY goals and signing up for the Speak Up Pledge. And then step three, attending check-in calls, again, because this is a journey, not a sprint. So afterwards, we still keep in contact with them. I actually do birth equity coaching with different facilities, and then doing the part 2 and 3 of our Speak Up online education. And then finalizing the Speak Up Quality Improvement Action Plan. One of the great things about COVID that happened, if you could say that there's a great thing, was that we went from in person to online. And so we have a 4-hour course one week, and then the next week they get the initial like baseline education. And then the next week we come back and we ask about, now, how do you see the world having had that baseline and that initial education? And some wonderful insights have come through actually. Actually, a Dr. Deborah Taylor from Georgia was actually quoted on the Hear Her CDC campaign because she had such wonderful insights about her practice. She was a white clinician and thought about how she had treated a mom, and came back to the education very remorseful and saying, I didn't even realize that my implicit bias has stepped into how I cared for this mom, and I want to do differently, and I want to be different in this. So it's those moments that really help people move the needle on this, because it's not how we show up as Black people in healthcare, it's how we're treated when we arrive there. So that's the important aspect of this, is also working on ourselves as clinicians. So we can go to the next slide. One thing that we're very proud of, and Dr. Meadows, myself, and a few others have been co-authors on this, is Black equity modules. And what they focus on is the 4 most important goals that organizations and institutions need to focus on to become equity minded, create a culture of equity, and really move the needle forward on what can we do to make sure that we're treating patients equitably and individualizing care. And the 4 goals have to do with creating an anti-racist statement, enhancing data collection. Again, Dr. Meadows talked about race and ethnicity. Are we looking at our data based on that? Because it could look globally great, but if our patients who are Black and brown are not doing well in those numbers, then we need to look at that a little deeper. And we know from the rates of the Black maternity crisis that we're not doing so well. So enhancing that and improving that, and it gives you tips as to how to operationalize that in your organization. And then equitable debriefing that includes families. It's not something popular, but it helps because patients mostly, when there's something that goes wrong, they want to be included and they want honest information about what has occurred. So we want to prevent things from going wrong, of course, but we want to also involve our patients if there's a near miss, or if something went wrong, or even if there's something good, just having that open conversation with them. And then maternal care standards, making sure that what we talked about the equity bundles, we talked about the AIM work, making sure that we have the care standards. The most important takeaway is that care standards are not enough. We've had checklists. the Black maternal mortality rate is still worsening. Okay, it's not getting better. So we need to look at how we're treating patients when they show up. And you can go to the next slide. Or unless Dr. Meadows or Melissa, did you want to add anything?
I think the biggest thing also, like, this is all fantastic. And I think the biggest thing, if you're not feeling like you're being heard, it's okay to say as a patient, I don't think you are hearing me. Because sometimes you just need to kind of shift a little bit to say, like, I don't think you're hearing me. This is what I'm trying to say, and that is okay. Because sometimes as providers, whether you are an RN, midwife, MA, whoever is working in that team, sometimes it's a little bit of saying, hey, I don't think you're hearing me. This is what some of my concerns are. And that is okay to be able to state that. Because, I think when you think about these relationships, it's a partnership, right? Like, you are bringing yourself and your family into this. I am bringing myself and my team into this. And, sometimes relationships they may not always be the best, but sometimes you got to kind of push through a little bit. But then a lot of the times, if you have that as being the foundation, that definitely helps. And I think honesty, I think my big thing when I give care to patients is that I'm saying, hey, I'm all about supporting you, supporting your desires, making sure that this is an experience that is a memorable experience, because patients will remember down to the scent of what you looked like, wore, and all of those things. But also, I think it's also important, the honesty is also me also saying, like, hey, I know you may want X, but this is what I'm actually seeing here. And being honest and saying, I don't think I'm thinking, I know you want this, but this is what I'm thinking, and this is why, and then respecting that honesty in both ways. So it's okay to also say, I don't think you're hearing me. And then also ensuring, like, when you're thinking about those places, are they doing programs such as what Dr. Meadows and what Renee is also talking about in terms of the Speak Up programs, is in the birth equity modules, because those are important things to hear what people have to say.
All excellent points.
While you're coming to the next question, Mary, if you don't mind, I just wanted to comment on one thing in the chat. I just want to say thank you to Renee for her description of this, but also for her work. I really want to just uphold and highlight 1,600 professionals across 37 states now talking about birth equity. I just want to pause on that and make sure people recognize how this is not something we could say in 2014 and 2016. That wasn't happening. And that's really important, and it's really huge. And it plays a role into what I was going to comment on and to the chat. So Malcolm had asked about APGAR scores. And, I put in the chat what the APGAR score was. The APGAR score is a system that we use, and really pediatricians use, to measure the health of a newborn immediately after birth. So there's an APGAR score given at 1 minute of life and then at 5 minutes, and it measures 5 what we call vital signs through appearance, pulse, grimace, activity, respiration. It helps us to decide when we need to intervene. And importantly, something I'm going to relate back to that and to what Renee was just saying, which is, when we're doing things like scoring systems, the scoring system inherently, I can't see that it's racist per se. But anytime you're thinking about systemic racism in healthcare systems, you're thinking about, do people have access to care? Is the quality of care as well as good as it is in other places? Those are things that are parts of systemic racism that, creates a hierarchy, right? A system where people receive better care simply because of where they live or their income or education or racial appearance versus another group of people, right? So that's what we're trying to eliminate and avoid through talking about birth equity. And in asking a question like that, I think about how sure there could probably be some differences in the quality of someone's training. So nicely, when you have these conversations through Speak Up training and other birth equity modules, people are learning about what is systemic racism, because many people don't know and didn't know before we started these conversations. And they're learning about how, when they look at these different things, what is it that I do, like an APGAR score, that may or may not lead to over intervention or under intervention. We don't want to be over medicalized in the healthcare system at all. We just want the right amount. You also don't want to be under medicalized, because that's where we run into trouble, where you aren't treated in a timely fashion, a disease system or some problems not recognized quick enough, and you haven't intervened quick enough. Interestingly, I'm just thinking out loud with APGAR scores, like if your score is a little bit lower, it gets more attention actually. It doesn't necessarily mean over intervention, but it gets a little bit more attention. So it's probably not always a bad thing. But the goal would be that you have people trained well to give the appropriate and the correct APGAR score so that we know that infants and newborns are doing well right after birth. So I just wanted to comment on that and make sure that people recognized and heard that, through the work Renee and her team that she leads is doing, 1,600 individuals that beforehand did not know. And this is 1,600 individuals that many of them being nursing directors and leads, clinical leads and midwifery leads that are teaching others. And so that has tentacles, that spreads. And we're having this conversation. People now know what that is. And that's why we're hopeful and expecting that we're going to see improvements in these outcomes because we're starting to have these conversations in a different way.
That's wonderful. And yes, it is to train that number of people. And it looks as if it is very intensive training. It's not a 1 hour, go sit through it and you're done type of training. So I'm hoping that it gives people a really rich opportunity to understand their bias. And I would submit that bias is not contingent on race. We've all seen, we probably have all seen the Origin movie, and we understand that it's also based on a lot of other factors, including socioeconomic status. And so, so we fast forward, we've vetted our care providers. We've vetted the hospital. We've carried our little baby now, and we're going in to our 37th, 38th week. And all my girlfriends are saying I should get induced. Can we talk about induction? And until you get pregnant, you probably don't even know what induction means, right? So can we first define what is an induction and then the process? And then maybe we'll change it up a bit and do a little fact versus fiction around it.
Yeah, so I think when you think about inductions, there's different types. So induction means you are giving a medication, right? You are giving medications to help start the labor process, right? And that is different from augmentation, which means you might already be in labor, but maybe you're at a point and you've been hanging out at a certain centimeter, things like that, and you need a little extra push to kind of keep things going, okay? And there's different aspects of induction. So for the purpose of this, I think we have to also make sure we're thinking about what is considered an elective induction versus what's considered a medical induction, okay? There are many individuals that can have a variety of medical issues that are going on where a recommendation for induction is before medical reasons. So for example, if you are somebody who has type 1, type 2 diabetes, if you are somebody that has diabetes in pregnancy or or you have gestational hypertension or preeclampsia, right? Those would be medically indicated inductions versus what people are probably hearing a little bit more is something called more elective inductions at 39 weeks. And, this is a great decision. I'm glad we have this up. Partner to Decide is a really great tool that I even use with my own clients where we're talking about induction. And I just want to make sure that we understand this Partner to Decide is for folks that are having elective inductions. This means an induction at 39 weeks, an induction at 41 weeks, where relatively, let's say if you're 41 weeks or past your due date, this is more for those. This does not include your medical indicated inductions, right? And I really think what I like about this tool, it breaks down all those risks, right? So when people talk about risk of something happening to the baby, risk of blood pressure issues for you, risk of baby possibly going to the NICU, this really breaks it down in a way that it allows you to have a real honest conversation that doesn't have really any bias and kind of centers like, what are your goals? What are your expectations? What are some of your goals and desires and what align? So it talks about an induction at 39 weeks. It talks about an induction around 41 to 42 weeks, or just waiting for spontaneous labor and what that actually means. So that's kind of a little bit of my spiel. I'm not sure if Dr. Meadows or Renee, you want to be able to add a little bit into that, but that's kind of just like a brief synopsis of and what an induction is, and you induce it with different medications, but then there's also medical reasons why you would be induced versus, an elective induction.
I think so too. If you want to go to the next slide, Marie, I think the next slide sort of says it all. It's our good friend Ann Peralta, who this is her organization, Partner Decide. She's created the web page and the slides that you see here. In the end, when you talked about, being recommended for an induction between 39 and 41 weeks without a medical reason, it's your body, your labor, your birth, your baby, and your choice. The issue is, what do I need to consider? What do I need to think about in making this choice? And so I think that becomes a big part of it. And what are the tools out there to make those kinds of decisions? If you go to the next slide, this is one of the tools that exists on Partner Decide. So if anyone goes to this web page, there's a printable paper version, there's an interactive web version, there's a QR code at the top if you want to scan for it right now. What's interesting also is on the web version and paper version, you can choose your language. See the list of the options to the right. And what this is just a decision aid for pregnant people with no medical reason for induction. Because that alone, there are lots of conversations around having the medical inductions, right? So that is one set of conversations. It's not what we're talking about. We're talking about the mini inductions, though, that people have to consider when they don't have a medical reason and they're between 39 and 41 weeks. And I keep harping on the 39, as you said, you're at 37, 38 weeks. We do not recommend, and no one should recommend, because I'll sound like a broken record. One of the very first safety bundles was the no elective inductions before 39 week safety bundle, because we were trying to make sure people weren't being recommended or asked to have babies too soon for many good reasons, because there are issues that happen when babies are born too soon, too small. And they may have to then be over medicalized, end up in the ICU when the best incubator wasn't the one in the hospital, it's the one you're carrying every day, right? And that's where we wanted the baby. And so we want to make sure that the baby's there as long as possible for everyone. Now, there may be medical reasons why maybe then deciding to deliver, it means that it's safer for you and baby to be delivered sooner than that 39 weeks. And you should have a different conversation with your provider when that's the case. But when it's 39 to 41, someone said earlier in the chat, and I'll answer it a little bit with this, which is, and I'd love to hear Melissa and Renee speak to us too, but the rush, my goodness, there are so many things to be said about why you may not have a lot of time with a provider in a visit. But I like to say and share, one, if you have the opportunity for group prenatal care, please do. If you qualify for group and you can do group, that is one way to get way more time with your providers than you do in individualized care. And that's, whether the centering pregnancy or however else a place does group prenatal education and care. So that's that. The other thing I'll say about it is, when I care for patients, I'm going to see them a number of times, somewhere between 9, sometimes and 14, 15 times during a pregnancy. And if that's the case, we will get time. And I give little nuggets of all the things that we're working on, starting off in the very beginning with letting people know what I think they should be reading, or if they're, asking what they're reading to prepare for giving birth, and making sure that they have a text or that they have an app or that they're working with something. That's really important because in that way we can have really good conversations when you come in. Your one face-to-face visit is not the only time you can communicate. You can also have conversations like Melissa started this conversation off really great with the team. Sometimes your questions can go to the nurses and other people. Our medical assistants are well-versed in explaining a number of things and providing information as well. So there's that. Having your childbirth prenatal education classes, even if it's not within group prenatal care, really important. And there's lots of different places and spaces and ways you can get that education. And that's what we then bring in all the many different faces of those who care for folks. We're trying to turn the tide on this maternal health crisis, and particularly the Black maternal health crisis, whether that be, like, for instance, in San Diego County, there's the Black Infant Health Program, the Perinatal Equity Initiative. There's so many groups and so many different ways you can get that information. I would urge someone not to rely specifically on their clinician for all of their prenatal information as a sole and single source. Now, if you're not getting time to talk about your medical conditions or your obstetrical clinical conditions, that's a little different, and you should get that time. And you want to ask about that or let people know what it is that you feel like your questions that aren't being answered. But when it comes to thinking about the totality of the experience, there is a team of people around you, and I'd say utilize that full team of people.
I agree with Dr. Meadows. I think also even thinking simple things, write your questions down. There's many visits that you're having. So really writing your questions down, really thinking about what is pertinent. And also remember, like, you can start asking questions. I have patients starting to ask questions about, should I get an epidural? And they're only like 20 weeks. And I'm like, okay, let's talk about these options, because it's a continued conversation. And I cannot help so much that those childbirth education classes, if you're thinking, if you're a parent and you have people who are like, what do you want? Let them pay for your childbirth education class. It doesn't have to be one affiliated with the hospital. It can be one that you like that might be more you know, gender inclusive, language inclusive. That might just be more along the terms of what you desire too. So just think about writing those questions down, and trust me, like, come in with those questions, but also know that it's not just your provider, it's your nursing staff that can be able to help you, and really being able to engage those individuals as well.
Wow, such rich information. I don't know about y'all, I've got pages of notes, and I'm not even having a baby. And we're running out of time. We've run out of time. We have 1 minute. So I won't waste it. I'll let you all close with some kernels, gems.
I just want to say thank you for all of you that are on the call and listening in and participating. This takes a village. I love Malcolm's last question that I see, which is, can social workers and community health workers help? Absolutely. This looks like a challenge to many people outside of us. I continue to see the maternal health crisis as our opportunity. And this is our opportunity for all of us to come together and be that village that we know is necessary to get past this crisis.
My nugget is that you are important. And I think my biggest thing is just finding that individual that respects you and that wants to be able to take care of you, and shop around. There's nothing wrong with shopping around. Okay. Nothing wrong with shopping around.
And I just want to add lastly that it does take a village. It takes doulas, it takes nurses, it takes physicians, it takes midwives. We want to provide good care and we want to receive good care. So don't be afraid to, like all of us are saying, just kind of ask questions, and clinicians, listen to your patients.
Thank you. Thank you all for joining us. Thank you to my esteemed panel. This recording will be available. Someone had asked, Dr. Meadows et al., will we provide the slides as well? Do we want to?
I actually just put all the links in the chat. I said to
Oh.
someone, you know, everything's here, and just these links, the AIM bundles link, the PQI, and the partner decide induction tool. So if you want to even put those on your webpage, they're just screenshots of those web pages. They're not anything special for slides.
Okay. And when we send out the record, everyone that registered gets a link to the recording, and then it's also on our YouTube channel. And so we'll include the chat. Thank you. We never got to even discussing the rest of the labor. Like, what if I have to have a C-section? Can I have a vaginal delivery next? So we may have to have a part 2. But this was wonderful. It was obviously something that needed to be discussed, and we appreciate your time. Coming up right now is Cocoa Care and breastfeeding. So we're going to fast forward you through the labor and delivery and talk to you about breastfeeding that little one. So see you guys in just a sec. Thank you, ladies.
Thank you.